Marie was totally edentulous and suffered from severe bone atrophy, but in 5 days, Dr. Genchev completed the full dental restoration with immediate loading implants. This video explains Dr. Genchev's basal implantology protocol by presenting its application in a real case study. Dr. Genchev is one of Europe's leading basal implant dentists. He specializes in patients' severe bone atrophy. Patients seek his help from all over Europe, as well as the USA, Canada, and Australia. Dr. Genchev has developed his own protocol for basal implantology. His cases are documented in 6 languages on the website of the Basal Dental Implant Association. Before the surgery, Dr. Genchev analyzes a high-quality 2D OPG panoramic X-ray to plan the procedure. He assesses the height, width, and density of the bone in each area of both jaws. Dr. Genchev always starts with the lower jaw. He begins by tackling the most difficult zones that are usually at the back. In this case, Dr. Genchev used 3 implant types from ID Dental. BCS for pure cortical anchorage, TPG-1 for dual cancellous compression and cortical fixation, and COS-root for cancellous bone compression with optional cortical anchorage. On the lower jawbone, there was cancellous bone. It was relatively high, but it did not have width. Dr. Genchev selected COS-root implants because they provide stability by compressing the cancellous bone. All implants are 3.5 millimeters in diameter to adapt to the available width of the bone. Dr. Genchev focused on selecting the appropriate length implants to create stability whilst avoiding damage to the mandibular nerve canal. The right posterior mandible, zone 46 and 47, had limited bone height and insufficient width. Dr. Genchev selected COS-root 3.5 by 8 millimeters. Slots were prepared with slow speed rotation and a controlled lingual inclination. Dr. Genchev used the width of the bone to position the tip of the implants lingually behind the nerve canal. The implants are anchored into the mylohyoid line, the cortical ridge on the medial side of the mandible that always remains densely mineralized. This cortical anchorage gives the implants exceptional primary stability despite the limited bone volume. In the left posterior mandible, zone 36 and 37, Dr. Genchev also used the mylohyoid line for cortical anchorage. In position 37, he used a 10 millimeter implant because the local bone height was slightly greater, and in position 36, he used an 8 millimeter implant. The implants are placed above and behind the nerve canal. In the anterior mandible, zone 32 to 44, Dr. Genchev placed 4 COS-root implants, 3.5 millimeters. The implants' lengths were adapted to local bone height. In position 32, 15 millimeters, in position 43, 12 millimeters, in position 31, 10 millimeters, and in position 44, 8 millimeters. The COS-root implants compress cancellous bone to generate primary stability. The even distribution of the compressive implants on the entire length of the jaw and the wise selection of height and length guarantee excellent support for the dental bridge, and Dr. Genchev's expertise means that he avoided the mandibular nerve canal. The maxilla, upper jaw, was more complex. Bone height, width, and density were uneven. Dr. Genchev chose a combination of implants to adapt to the different quality of bone in each zone. On the right posterior maxilla, the cancellous bone had resorbed entirely. Only the hard cortical bone remained. Dr. Genchev selected BCS because they're designed for cortical fixation. He placed 4 BCS implants. In position 17-2, he placed the primary tuberopterygoid implant. A 3.5 by 20 mm BCS was inserted at a posterior oblique angle to reach the medial plate of the pterygoid process of the sphenoid bone. In position 17, he used a BCS at 4.6 by 14 mm, inserted through the tuberopterygoid junction. The dense cortical bone structure of the posterior zone never resorbs and provides immediate distal support for the bridge. In positions 15 and 16, he used BCS at 4.6 by 14 mm anchored into the cortical bone of the vertical process of the palatine bone. A wider 4.6 mm diameter increased the cortical contact surface for greater stability. The left posterior zone retained both cancellous and cortical bone, so Dr. Genchev selected TPG-1 because their threaded body compresses the cancellous bone and the aggressive tip anchors into the cortical bone of the pterygoid process, and they're polished to avoid bacterial colonization. He placed 3 TPG-1. In position 27, Dr. Genchev used the longest implant at 3.5 by 17 mm to reach deep cortical anchorage in the pterygoid plate of the sphenoid bone. In position 26, he placed a 3.5 by 12 mm TPG-1 in the pterygoid process. In position 25, he used a 3.5 by 12 mm TPG-1 attached to the pyramidal process. The 3 implants were sufficient to support the bridge because they use both the cancellous and the cortical bone layers. The anterior maxilla, frontal area, zone 14 to 23, had good bone height but very limited horizontal width throughout. There was dense cancellous bone, and above it the hard cortical bone of the nasal floor cortex. That is a highly mineralized structure that provides a second cortical anchor point for basal implants. Dr. Genchev selected Cos root because its rough surface compresses the cancellous bone to generate primary stability through friction, and the top 4 mm of the implant are polished to avoid bacterial colonization. Dr. Genchev placed 7 Cos root implants, all at 3.5 by 16 mm. They were inserted with a slight palatal inclination. Each implant compressed the cancellous bone, and each tip was fixed into the cortical bone of the nasal floor. A 3.5 mm diameter was the maximum safe option given the narrow bone width. Dr. Genchev strategically placed the 7 implants to evenly distribute the load of the forces of mastication. For the patient, it translates into a long-term solution for eating normally. The exceptional stability of each implant placement and the immediate loading functionality of basal implants meant that Dr. Genchev could place the final dental bridges 4 days after the implantation. In order to avoid any micro-movements of the implants during those 4 days and to help the bone regenerate faster around the implants, Dr. Genchev joined the implants together with a photopolymer. Dr. Genchev's prosthetist created made-for-measure bridges to compensate for the patient's prognathism. The reverse bite was corrected by adapting the dimensions of the crowns, their inclination, and the occlusal contact points to restore a functional occlusion. The stability of the 22 implants could support PFM metal ceramic bridges with 14 crowns each. Despite severe bilateral bone atrophy, Dr. Genchev achieved high primary stability across all 22 implants. This once Edentulous patient went home to France with a full set of teeth. She could eat normally and smile with confidence.